I think educating patients of like what can happen, and those are the symptoms you're really looking for to decrease this from getting to the severe level, is like the sensory stuff is kind of your starting point, and it progresses from there.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Colleen Erb, Hematology and Oncology Nurse Practitioner at Jefferson Health Asplundh Cancer Pavilion in Willow Grove, Pennsylvania, about what nurses need to know about cancer and treatment-related peripheral neuropathy. This episode is part of an ongoing series about cancer symptom management basics. The others are linked in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Colleen.
Thanks so much for having me. I'm excited to be here.
Wonderful. So for this series, we always like to kind of start out with what's normal before we move on to what is potentially abnormal. So to kick things off, can you start us with just a brief overview of sort of the general physiologic functions of the neurologic system, and how can cancer and cancer treatments potentially compromise those functions?
Generally, our nervous system is sort of divided into three parts. The sort of autonomic nervous system, which is kind of controls homeostasis, blood pressure, your intestinal motility, things like that. The motor system, which is the efferent system, which is reflexes, muscle strength, sort of your big muscle movements, if you want to think of it that way. And then the sensory system, which is the afferent system, which is really what the fine motion. So you have your large and small axons. The large ones are like vibration sensitivity and proprioception, which is really just a big word for being able to tell which way you're moving and which way your limbs are moving. And then the small axons, which really are temperature and pain. They're the sort of ones that we think of the most, honestly, in neuropathy. And really, like underlying sort of cancer and all of our treatments can potentially affect normal function, some more specifically than others, which we'll get into. But cancer itself can really affect them too. So kind of that damage kind of causes some degeneration in the axons, and it affects the myelin sheath, which is the protective casing around your axons. That myelin sheath really, when you start to disrupt it, leads to the decreased electrical conduction that your nerves need to function. So we really generally don't know what causes peripheral neuropathy, but we know that those are the things that can be damaged.
Sure. That's definitely a good place to start to give us that sort of foundation of how it works in an ideal state. But as you mentioned, we know that many, if not seemingly all of our systemic cancer treatments seem to have at least some potential risk for causing certain neuropathies. So let's talk about peripheral neuropathy presentation. Like, what are the different categories of how it can present?
Like you said, a lot of what we give can affect your nervous system in general. You know, you have like this technical definition of peripheral neuropathy, which, you know, it's this very long definition of disease and degenerative state of the peripheral nerves in which the motor, sensory, or vasomotor nerve fibers may be affected and can cause muscle weakness, atrophy, pain, and numbness. Really, it just means that we have peripheral nerves, and most of our chemotherapies tend to affect those nerves because they don't cross into the blood-brain barrier to affect the central nervous system. So you really start to find presentation of like numbness, pain, tingling, burning, that paresthesias, like that prickly sensation when your fingers and your hands fall asleep. If you fall asleep on your hand and you get that like weird prickling. And then things like sensitivity to cold, particularly with certain chemos like oxaliplatin. And it's generally a subjective thing. You know, you find patients start to complain of these like in their fingertips and in their toes, and you find it in this what's called a glove distribution because it starts in your hands and your feet, and it can progress distally sort of towards the center of the body. Some people have an electric shock feeling, particularly in their lower extremities, and that's more of a sign of like the large fibers being involved rather than just the really small fibers. And, people start to have things like a decreased ability to grasp or hold on to things like pots and pans and jar lids and door handles and things like decreased ability to button or zipper things. The writing can start to be really scratchy almost. I have one woman who's like, my writing just looks totally off. It's not the same. And that was the only thing she complained about because she was writing Christmas cards and that was her complaint last week was that her writing didn't look good. But people start to notice those things more than anything else.
Well, I think you've brought up a couple of good things to call out. There is a separate sort of collection of conditions that are more central neurotoxicity. That in itself is probably going to be its own episode. So what we're talking about today is more of that peripheral. But, there is the possibility that a central neurotoxicity can present based on other agents that we know are out there in this space as well. But when we're talking about that peripheral neuropathy, as you mentioned, we, I think, instinctually will think about the sensory neuropathy, which is probably more common, but there's also a component of motor neuropathy where sometimes it is actually, muscles aren't firing the way they used to. They can't feel things the way they used to. So as you mentioned, some of that fine motor skill really starts to be compromised. And it could be a component of both sensory and motor neuropathy working in tandem, unfortunately, to cause that presentation.
Yeah, absolutely. I think patients tend to blow off the mild numbness and tingling because they're just like, oh, it's just the side effect of my chemo. And they don't realize that can get progressively worse. So they tend to not tell you, oh, do you have numbness and tingling? You ask it at every visit, but they're like, no, it's fine. It's just once in a while. And all of a sudden, 2 months down the line, they come in and they can't walk as well. And you're like, well, what's going on? Oh, well, my neuropathy's been getting worse. But, I had one patient tell me, I knew if I told you it was getting worse, you wouldn't treat me. I was like, oh, goodness.
I mean, that's a huge piece of education. You're absolutely right.
So, I think educating patients of what can happen, and those are the symptoms you're really looking for to decrease this from getting to the severe level is the sensory stuff is kind of your starting point and it progresses from there.
So let's talk about specific agents then. What are some of the primary causes, specific agents, or maybe even some associated risk factors that a patient could have, comorbidities perhaps, that can put them at a greater risk for developing peripheral neuropathy during their cancer treatment?
Yeah. So, I think everybody thinks of the big three that we all know cause neuropathy. It's like paclitaxel, docetaxel, oxaliplatin, and then there's the other ones that are all of the platinum agents, cisplatin and carboplatin can be added in there. Your vinca alkaloids, specifically vincristine, but the others like vinblastine can do it too. It's just a little less frequent than vincristine. Things like proteasome inhibitors, mostly bortezomib, but the others still have the risk as well. Drugs like brentuximab, vedotin, arsenic, thalidomide, gemcitabine, and all of those associated classes, which generally is pretty much every class we give.
Right.
But those are kind of we just named pretty much all of them. But those are the specific drugs that we know cause this a little more often. But there's lots of other risk factors and comorbidities and things like that go into it. There are some risk factors, patient risk factors that we know can cause some issues, like people being over the age of 60, having pre-existing peripheral neuropathy from an inherited neurologic disease or diabetes or peripheral vascular disease. The site of their disease, there's a lot of people that present with things like pressing on nerves. Tumors are already causing that neuropathy or it's affecting their nervous system to begin with, like their brain or their spinal cord. So they've got sort of pre-existing issues that will just make that worse. Some other disease-related comorbidities, things like diabetes, thyroid disease. There's nutritional deficiencies, like vitamin D is a big one. So we tend to check B12, but B1, which is thiamine, can also cause this. Things like inherited neurologic disease, toxin exposures like alcohol and people with alcohol dependence, infections like HIV and herpes or shingles, as we all know it, cardiac disease, which, peripheral vascular particularly, but other cardiac diseases can do it too. And then medications that people have been on forever. There's a list of like the highly likely ones, things like amiodarone, aminoglycosides, colchicine, hydralazine, metronidazole, linezolid, and statins can actually cause a pre-existing peripheral neuropathy or make you more likely to develop it in the duration of your cancer treatment.
So it basically sounds like everyone's like either set up to already have it when they come to us, or what we do, we'll make them develop it. Everyone's getting neuropathy.
Exactly. No, I feel like there's so many things that you're like, oh, so pretty much every patient that walks in the door is going to be at some risk. And I feel like that's probably the case. I think just assessing everyone is really the best way to go, because you never know. Like, people are going to be on other medications that may be causing this, or other diseases that are totally unrelated, but now we're giving them chemo and it's going to make it worse.
Well, you're absolutely right. And it's almost sort of that universal precautions kind of approach where it's like, just assume that everyone has a risk, or maybe already has some already pre-existing concerns or associated, whether it's medication therapy or comorbidities that kind of put them at an increased risk for this. So as you said, everyone should be assessed. Let's talk a little bit more about that assessment. What are some of the specific points that nurses should consider as part of a comprehensive assessment for drug-induced peripheral neuropathy? So we know a patient's going on a drug that has a likelihood of creating or worsening neuropathy for them. What are some of the things that they should consider maybe before a patient even starts on that drug, and then sort of as a routine part of that assessment?
I think the most important thing for any patient, but specifically when you're looking for peripheral neuropathy, is a really good history and review of systems like other medications, any supplements, any comorbidities, any underlying diseases that they may not be treated for yet, or things like that. But a good history can really go a long way in finding out sort of your risk factors. A lot of times it's really sort of inconsistent as far as finding peripheral neuropathy or assessing for peripheral neuropathy, because there's really no standard assessment for peripheral neuropathy. There's a whole bunch of different scales and everybody has their own set of questions, but there's really no standard out there. So I think for nurses, like, our biggest thing is to determine, like, once they start to have peripheral neuropathy, what's the severity, what's the effect on their quality of life, and really get a good idea of what they're able to do versus not able to do, and where were they before they started chemo. Our measurement is kind of self-report. There are some objective clinical assessments and grading and things like that you can do, but a lot of it is reporting what you can find. I think a lot of it's underreported because patients, like I said earlier, I think it's just normal side effects and they don't tell you. And I think a lot of it's inconsistent because we don't have that standardization. So things like asking, has anyone in your family had a neuropathy? Because there are some inherited ones they may not even know about, and it just comes to light because they're starting chemo and we just sort of kick it into high gear. And I think nurses knowing how to do a basic neuro exam, we all learned it, but do we actually do it all the time? Probably not. But I think really knowing how to, can they feel light touch or a pinprick? How's their muscle strength? Watch them walk down the hallway and see if it changes over time. Like, are they starting to sway a little bit when they walk? Can they get out of the chair without pushing on the handles, and using their arms to get up? Things like that really can tell you a lot. And then there's the further down the line, like vibration sense with tuning forks and things like that. But I think just being able to do the easy ones, like muscle strength and gait, and whether they can feel you touching normally, like a light touch, is going to go a huge difference.
I think those are all great techniques to consider. I like how you pointed out we could use more objective scales, CTCAE grading criteria, things like that. But because it is a subjective experience for the patient, sometimes you have to ask questions that connect the sensation to an activity for them to really gauge if it's getting better or worse. I think we all know, like, if you ask a yes or no question, do you have peripheral neuropathy? As you've already kind of hinted at, sometimes we'll get oh no, I'm fine, when it's like not really fine, but it's fine enough. And so asking those more directed questions like, are you able to still button your shirts? Can you, zip up your jacket? Can you pick up a coin from a table? How's your handwriting? Those types of things that maybe the patient might not themselves connect with a neuropathy, but we know that those will be those key indicators that fine motor control is changing for that patient. And so being creative and asking those questions in a different way might help to elicit different responses. And I don't mean to intend to say that all patients are like intentionally trying to deceive us on how bad their side effects are. But we do know that, patients, if they think that their dose will be lowered or their treatment will have to be held, and they don't want to do that, for all the reasons we know, like we just sometimes have to pull on a couple different threads to make sure that we're getting a comprehensive answer to some of these questions, because there are some things that we can do to hopefully help mitigate or lessen the chances or minimize the severity of peripheral neuropathy. So let's talk a little bit about that. What are some of those strategies that when we're talking about drug-induced peripheral neuropathy that we would likely implement if patients start to report worsening of those symptoms?
Yeah, absolutely. I'm going to go back for 1 second, only because this is my new favorite question. Can you text without problems? Because when you start to not be able to have that fine motor skill, you start missing letters and you're hitting the wrong letters. And so it actually makes people think about it and they're like, no, I just keep spelling things wrong. It's surprisingly a good question.
Autocorrect might make that harder though, because I spell things wrong all the time because I'm just not taking my time and I'm like, oh, don't worry, it'll fix it for me. But you're right, especially if they, if they're using, or even when if they're typing in a keyboard, I mean, that might be something where they can't type as fast because their fingers aren't as responsive. And so that might be indicative of some issue. That's a great question.
Okay. Back to your question about preventing and minimizing the severity. Sadly, there's really nothing proven to prevent the development of neuropathy. We know that you can't really catch it before people start having symptoms, unfortunately. It's really when you start to detect symptoms that you can prevent it from getting to the severe point where it's really impacting their quality of life. And I think the biggest thing is proactive assessment and diagnosing it when it's early and being able to kind of intervene before it gets to the point of debilitating. It's kind of hard to figure that out sometimes, but we know that assessment is the best key, making sure that you're asking those questions every time they come in. We tend to tell the infusion nurses, if the providers are seeing people once every cycle, you're seeing them every time they come in for treatment. If anything changes, that's your cue to let the providers know, maybe we need to intervene here. So, I'd love to hear from the nurses, hey, this person really, they're starting to have some issues. And they didn't tell you last week when they were here, but we just saw them try to pick up something in the infusion room and they can't, or they can't open something, they can't open a can when they used to be able to. Really treating their pre-existing conditions is a huge part of this, maximizing treatment for their comorbidities that could impact peripheral neuropathy. One of them is diabetes. We start people on chemo and they get steroids for their pre-meds, and then we shoot their blood sugars way up because we're giving them steroids for pre-meds. And I think really watching their blood sugars and not just being oh, it's the steroids, it'll come down when you're not on the steroids. Making sure people know to really watch their blood sugars a lot closely while they're on this. And then education is huge for safety. And really, when you start to see progressive symptoms, it's things like delaying treatment or dose reductions, or people who are really severe cases, you have to discontinue the drug or you're just going to be completely debilitated, unfortunately.
I think you've really called out a really important point of really not minimizing the impact on quality of life. This isn't necessarily a lethal side effect when you think of other things, nausea, vomiting, diarrhea, blood counts, and I think that's part of the education, right? Patients might think of neuropathy, no big deal. I'll worry about the big stuff. But this really becomes a critically important piece of their life. It can really impact it. And as you mentioned also, when you get to, lower extremity neuropathy and not being able to feel where your feet are and tripping and falling, it becomes a safety issue. And so we really, without scaring anyone, we do have to be very clear and emphasize up front, this is not something to overlook or blow off. This can become a really important side effect that, as you mentioned, we have no great means to improve once it happens. And so our best course of action is to know as soon as you start to feel it so that we can make those dose adjustments or, change the cycle or whatever the right treatment plan alterations are for that patient so that we can hopefully minimize it and mitigate it the best we can. So that I think that's a teaching point for patients of just creating that sense of awareness of this. This isn't something that's a little thing. It becomes a big thing very quickly.
And I think patients, and I do think to some extent, providers tend to think of it like it's not the top of the list because, you're looking at their blood counts, you're looking at their nausea and vomiting and their weight loss, these things that can immediately impact their morbidity. But we have more and more survivors of cancer and better treatments. So now we have to figure out the quality of life. And this is huge for quality of life.
You got absolutely right. The notion of what this means for survivors, whether it's months, years, decades, we're seeing that now, which is wonderful. But now these types of side effects that maybe 20 years ago, when we weren't seeing the same survival rates, weren't things that were top of mind. But now we had to be very aware of, we're hopefully saving these lives with these treatments, but at what cost down the road? And so those are things that definitely have to be balanced. And I think as part of that shared decision making, those are important points to bring up to the patient to help them understand, we want to make these adjustments. Obviously, we want to give you the best treatment possible to provide the best outcome that we can. But these are the things we're balancing of pushing the dose or the length of treatment, but balancing that with some of the side effects that can be significant and longstanding or permanent. And we just have to have that constant dialogue about how you're doing. And is this the right balance for that patient? Are they getting the benefit they want and not feeling like too much of their quality of life is being compromised? So I know we've touched on a few things, but let's maybe focus specifically on patient education. What do you think are really the highlights of patient education that we as nurses need to provide to both patients and the caregivers about this cancer kind of treatment-related peripheral neuropathy?
I think this is where nurses are sort of key, is the education part of this for patients and their caregivers. Safety is the biggest one, especially when this really starts to become sort of their lower extremities are affected. Things like making sure that your temperature, like your water heaters have a max temperature. And if you can set that a little bit lower, you'll never have that scalding hot water that could potentially burn someone who can't feel it quite as well. And especially this time of year, making sure that people wear hats and gloves and protect their extremities from cold weather because you're just not going to feel it as quickly. And, you can end up with damage just from the cold. Non-skid mats in things like hallways that have lots of traffic or in the bathroom and in the shower and things, places like that. Making sure that throw rugs are checked to the floor and they're not just loose. There's lots of stuff that you can get that almost tapes it to the floor so it doesn't move. Furniture placement in your house to make sure that things are not in the way, that clutter is picked up so people don't fall over it. It's a lot more of the home safety stuff. Things like cold sensitivity. Oxaliplatin has this 48 to 72 hour period after you give it that people have horrible cold sensitivity, and the education around it. Everything should be at room temperature. You shouldn't go grab something out of the freezer because, it's really just going to be painful for them. I had a patient a few weeks ago that said, I didn't really think that was going to be as bad as you thought you told me it was. And I grabbed the ice for my lunch out of the freezer and dropped it because it hurt so badly. It was well, yeah, it is as bad as we thought we told you it was.
So I was thinking it's a mistake and usually an oversight, right? They just aren't thinking through. It's it only happens once. It only takes one time for them to really believe us, but you're right.
Yes. There's some other things that we can do as far as education and visual inspection of your hands and your feet to look for any sign of injury that you may not have felt if you start to have that sensory neuropathy. Wearing loose footwear and loose socks and things like that, or not wearing heels, limiting alcohol and recreational drugs that could potentially worsen peripheral neuropathy or just create an unsafe situation. And then really educating people on when to call, what symptoms they should report immediately or what symptoms they should tell you about at the next visit, and telling people up front that this is going to be a side effect. but we want to hear about it. We want to make sure that we can limit the effects down the road and how this impacts your life generally. So please tell us if you start to have symptoms.
I recall times when I was trying to educate patients that I was already close with, I would be pretty blunt. I was like, we want this drug to hopefully save your life, but not at the expense of you not being able to feel your hands and feet for the rest of it. Like, so emphasizing that it really is important, and they are the only ones that can tell us when they're feeling it. We don't have a way to know unless they endorse that, yes, they are feeling that way. I think you've given a lot of great examples of just points to emphasize. And I think you also kind of alluded that we can borrow tips and tricks from other disciplines, like for diabetes care and foot care. I mean, those types of techniques would be helpful. Obviously, our goal is to prevent our patients from getting neuropathy that is that bad. But if it happens, despite our best efforts, or they have other comorbidities that sort of drive the worsening of that, we could connect with our occupational therapy colleagues and understand, are there adaptive appliances or certain things that can help patients if they can't, don't have grip strength, if they don't have the ability to maybe like hold a fork when they're trying to eat. There might be other things that we can do if it really is that severe. But again, we hope to be able to intervene before at least the drugs we're giving would cause it to be that severe.
Absolutely.
Well, Colleen, we've had, I think, a great conversation today talking about a side effect that I'm sure almost every nurse listening has probably dealt with when trying to help care for their patients or provide education. So I think it's one of those things that we deal with all the time, but we should never become complacent about or just forget the importance of incorporating awareness of peripheral neuropathy in not only our patient education, but our routine assessment. So thank you for all the information that you've provided today in this episode. Before we end, I'd like to ask a few quick fire questions just to kind of summarize some of the topics that we've discussed. So to start that off, what are some common misconceptions about peripheral neuropathy?
One of them is that only chemotherapy can cause peripheral neuropathy. There are cases of peripheral neuropathy with radiation as well. So it's not just chemotherapy. And I think the combination can be a little worse sometimes. And that only people who are receiving high doses can actually present with neuropathy. It can really happen to anyone at any time. And generally with any drug, not just those ones that it's the top side effect. It really can affect any drug. So assessment is kind of key for everyone.
And what's something about this topic that's not often discussed, but you wish people knew more about?
That things like hearing acuity could actually be related to neuropathy if it starts to affect their central nervous system rather than just the hands and the feet. And I think people who are off balance or dizzy that say, I just get off balance when I stand up, asking further questions is a good thing to assess sort of for autonomic neuropathy, which sometimes affects people even without the sensory part.
It's a great tip. I think when I hear, dizziness or off balance, I think I gravitate towards the hemodynamic kind of compromise or dehydration. And so I think you're right. It's important to keep neurologic underpinnings as part of that differential, just to make sure that we don't miss anything. So that's a great tip. What additional training or education would you recommend for oncology nurses just to ensure that they're prepared to understand peripheral neuropathy?
I think, and I mentioned this earlier, I think it's really good for nurses to remember that basic neuro exam and to really use it occasionally because it makes it easier to remember. And that nurses are really the key in educating patients and family and keeping up to date on sort of the assessment skills and the most up-to-date treatments and things like that for neuropathy is good for patient education.
And what are some additional resources, maybe for either patients or nurses or even other providers who want to learn more?
I think the American Cancer Society has great stuff for patients on neuropathy. For nurses, I think ONS has the symptom intervention, which used to be PEP, or still is PEP in some places. It's kind of turning over to symptom intervention now. Has a great resource for peripheral neuropathy. And then ASCO also has a great guideline for peripheral neuropathy that it's kind of spelled out really here's your main point. You don't have to read the whole 25-page document. There's a quick summary at the beginning, which is really good. And then the MASCC has some great resources for neuropathy too. It's all about symptom management in cancer.
Wonderful. We'll be sure to link all of those references that you mentioned in our episode notes so that our listeners can have easy access to those. Well, thank you again, Colleen, for all of your information today. I really enjoyed talking about this. Do you have any final comments you'd like to share with our listeners?
I think my final comments are nurses are really key in this. The education part of this is huge. And I think that's just where nurses sort of shine, is that education piece for cancer patients and caregivers. Our patients are so much more comfortable with us sometimes. We know them better in a lot of cases. So I think especially for neuropathy, that comfortable feeling and the education piece is huge.
Absolutely. Well, I couldn't agree more. Thank you again, Colleen. It's been great talking with you today.
Thanks so much.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.